now we are limiting our procedure, but one day we need to restart. So hopefully in Italy, it will be in 1 month. So maybe in Hong Kong, in Japan, it will be in less or more time. So how to replan all of this burden of elective procedures, surgical and endoscopy that we now suspended. So how to restart? I'm curious to know what all the panel feel about it. How to restart in what we do.
So, thanks, Cheshire. I would like to comment because, as mentioned, we recently published the APSDE guideline on the COVID-19 for endoscopy. So, in the guideline, we also mentioned to describe one statement. It's about how to restart. So, I think from the perspective both from surgery and endoscopy, we are thinking that we have the few factors that we have to consider. First is the instance of the COVID-19 cases. I think as rightly pointed out by Ying-Kai, so if there's a trend of increasing, I think everybody will be only doing emergency endoscopy or emergency surgery. So, but then if you can see a downward trend, and maybe you have probably not looking into no case, because now we will have an asymptomatic case patient anyway, but we can see a downtrend in the case. And the second thing is the availability of the PPE. There's also always a stress to the hospital, and also the availability of the manpower, because I know in some of the hospitals they are deploying doctors from different specialty to help in managing the COVID case or to support the medical team in managing other cases, so that the infection team of the physician can focus on the management of the COVID-19. So in that perspective, you need availability of the manpower and also the PPE. So that would be also an important factor.
Ale, how will you restart in doing the elective procedure? How will you hierarchize the priority?
That's crazy, guys. So we don't really know. So we started talking about that since a couple of days. Once the curve started going down, flattening a little bit and now going down. So there is a lot of discussion. The main problem is still part of uncertainty, then is based on two issues. First, nobody knows what is the value of the rabbit test, the blood rabbit test. There is a lot of studies ongoing, upcoming, but we do not have data that can tell you that that test is really sensitive and specific. So we don't know exactly which tests are the best to give the sort of permission to go to the hospital. And the other one is capability, because even though we have decided that we do the swab test to everybody who want to get into the hospital, we did an estimation. In pre-COVID era, we had about, including outpatients and inpatients, about 6,000 patients coming into the hospital for any kind of activities, CT scan, MRI, radiology, whatever, ophthalmology, everything. So even though we decrease by 50 or 60%, we go to 2,000 or 3,000 person per day. We do not have the capability of testing 3,000 in few hours. Plus, there is no test available. So now most of the country, they have centralized the purchase of the test. So they deliver to the single hospital, but they don't give the amount of tests that would be required to get the patients into the hospital. So just crazy discussion. Nobody knows. A lot of scientists going in TV and giving recommendation based on shit. Everything is crap because they say things that are not practically doable. Because they say, okay, test everybody, but how you can get tested? Nobody knows.
Yeah.
So we are not allowed to test because we don't have the test.
Yeah. Haru, did the Japanese society provide any criteria on how to restart after the end of the outbreak?
Yeah, it's a very good question, and we have to discuss this. But still in Japan, the numbers are increasing, so we are discussing how to reduce the examination. You understand? So
Yeah.
reduce the number of surgery, elective endoscopy. We have controlled the number of cases. That current situation is right now. So we have to follow you are a little bit advanced. So I get some information from you. And but personally, I think it's officially very difficult to decide when we start the elective cases. At this moment, we are recommended to reduce the number of cases for elective patient, generally stop it, and then restart. The point is, of course, the number of new patient decreases, and the after that, so we have a full discussion with the patient, the necessity of the endoscopy, necessity of the surgery, and the risk of surgery, risk of infection. So we have to discuss with the patient carefully.